going with some cases. Okay, 72, I will scan the first, and after I'll give you the mic. 72 years old, follow-up of someone having a lesion 6 weeks later. You see here, 6 weeks after the initial MRI. How does the initial MRI look like 6 weeks before? It was a small little lesion here, okay, small contrast enhancement, and actually you see how it looks like only 6 weeks after. Actually, it was a metastasis of lung carcinoma, but you see on diffusion imaging, the restriction of diffusion is directly related to the cellularity of the tumor, and then it's explained why the growth is so important. Another case, a woman, 86, walking disturbance. Okay, the whole body screening was normal, but actually it was worsening. And it was described, it was described on the MR, a little tiny lesion in this area, you see? A little enhancement. It's absolutely abnormal. And it's especially abnormal when you look at the diffusion. Maybe on the main image it's not so obvious, but on the restriction, on the ADC map, you see that was dark, restricted, okay, suggesting that it was a highly cellular lesion. And what happened 3 months later, you had lesion everywhere, okay? It was, again, some mets from small cell carcinoma with a very high turnover. Okay, then this is a tumor. Maybe it's not the easiest one, but okay, I'll do it. It's a tumor of the pineal region. Okay, you see, intensely enhanced. What do you know as tumor of the pineal region? Yeah, 57. Yeah, but anyway, not a kid, not a child. Well, the restriction was not so obvious, but you have to deal with at least two, and I will show you two examples. Okay, you can talk about lymphomas. That's right. Okay. Glioma, well, midline glioma. Why not? But it was, yeah. This enhancement is not so typical from the diffuse midline glioma. Germinoma also. Okay. And usually germinomas, they have a really highly cellular lesion, and actually it was not a germinoma, it was a pituitary papillary tumor. Okay? Pineal, sorry. This is a mistake on the slideshow. Okay. Here you have a large lesion. You see a temporal lesion, which enhance with a peripheral enhancement. What would you have to what would you like to have? Diffusion, okay. Then it's abscess. We entirely agree. Okay, this one we've seen it just before, and it's exactly the same kind of cases. What I told you is that when you do spectroscopy into the necrosis, you won't see any in an abscess. In the past, you won't see any NAA, any choline, any creatine, but you will see acetate, lactate, amino acid, and sometimes succinate at 2.4. Then no NA, choline, creatine, acetate, AA, and lactate. Okay. Then here, we can start. You start? Do you want to start? You have got a microphone. It always come back to you. Okay. Can we try to go a little bit further?
So, because the enhancement lesion is so small and the edema is very large, I would expect that there is quite a aggressive lesion behind it, and there is also a second lesion on the left side.
That's right.
I can't see enhancement, but the edema.
Okay. Then we did a spectroscopy. Actually, this was a multifocal lesion. And what do we see on spectroscopies? And first, we don't see any peak of choline. Then, okay, it could be in a certain way good, but it's not. It doesn't look like a glioma. What do we see also? Here, at point 3, we have a small peak of lactate, okay, and at 0.9 we have a slight then this inversion, and also due to the presence of lipids. Okay. Well, can we try to be a bit more? The peak of lipids is very small. Then when you see two multiple enhancing lesions, you have to think of.
I'd rather think of infected flow.
That's right. We have to deal with infection or metastasis, actually. Infection, we don't have any high signal on diffusion. Okay, but the necrosis is not that big. And actually, we don't have any amino acid or whatever. And the peak of lipid is quite small. Okay, then it's rather on the metastasis side. Okay? Maybe another one. I don't know. T1, contrast enhanced T1, this is flare. Okay, then only on morphology. Okay, it can look like a diffuse midline glioma. Does the spectroscopy brings you additional elements? That's right. And then you have this high peak of choline. Okay, yeah, it was a diffuse midline glioma. It has been treated this way. Okay, here. Okay. Okay, no contrast enhancement. We did a spectroscopy with one voxel into the healthy thalamus and one voxel, this is the healthy thalamus, and one voxel into the abnormal thalamus. Do you think this is a normal spectrum? Then first what you see, the choline is a little bit above the creatine. but the ratio not that big, and still below the NA. Okay, then that's why sometimes it's interesting to have a reference region of interest in order to not mix and interpret a higher peak of choline as abnormal, especially when compared to creatine. Okay, but on the affected side, you see that this peak of choline is higher, and is also the ratio between choline and Na is above 1. Then you have actually a peak of choline. Okay, it was also a diffuse midline glioma. Okay, this one. Okay, no microphone. Everybody's dead now.
Hyperintensity.
Hyperintensity. Superior frontal gyrus and middle frontal gyrus on T2, looking a little bit infiltrating.
Yeah, or edema around it.
Or maybe edema, or yeah, okay. Then let's have a look to the spectrum. Do you think it's a normal or an abnormal spectrum?
Abnormal.
I mean, you have a high peak of Na. Choline is below creatine. You don't have any lactate, no lipids. It's a normal spectrum. Okay? Then actually, they didn't really believe, and everybody worried, and finally they went to the biopsy, and they found some sclerotic vessels, gliosis, and so on. We don't know exactly what was here, but it's a sequela of something. Okay? This, much easier.
There's this lesion in the cerebellum on the left side.
Mm-hmm.
With contrast enhancement.
Yeah. A nodule with a cyst. Okay. It can be metastasis. What else?
I don't know.
Hemangiobastoma. Pilocytic astrocytoma. And then can we try to distinguish all those lesions? Then first we do diffusion. It doesn't show you anything special. Okay, it's not pus. It's not anyway. Here you don't have highly cellular nodule, but perfusion. You see the ratio between the CBV of the nodule with the healthy side is about 10. Then what does it mean? I told you the normal value of CBV in a voxel is about 4%. Okay? Then when you compare, on one side you have 4% as a reference, and on the other side you have 10 times this, then you have 40% of your voxel, which is circulating vessels. Then whatever it is, it's an hemangio something. Okay? Then actually it was an hemangioblastoma. Okay? Okay. That one? Penile.
So there is this lesion in the pineal region, and in post-contrast imaging, it's
Well, quite a bit heterogeneous. On T2, what is striking? And when you see this T2, you can imagine the diffusion.
like it's hyperintense in T2 with hyperintensity around it,
Yeah.
like
Then you have an edema around
an
this
edema.
lesion, which is quite hypo-intense in a certain way. Okay? Then it means that it's highly cellular. If you look really, the intensity of the core of the lesion is very close to the cortex. It's very close to gray matter. Then you have a lot of cells. Okay? And if you do diffusion imaging, you see there's high diffusion, high hyperintensity on diffusion image due to restriction of diffusion. Then it's a highly cellular tumor. Okay? And in the pineal region, what is the most highly cellular tumor? We say it about lymphoma. That's right. It's an option. Why not? But in younger subject, teratoma, not exactly. There's not so many cells. Germinoma. Okay? And when you do perfusion, you see that there's a small increase of perfusion, but not that much. Mainly leakage, as it's shown by the contrast enhancement. Okay? Another tumor?
Well, there seems to be a tumor in the fourth ventricle, I think, with peripheral heterogeneous enhancing and central area of non-enhancing, non-enhancing portion, which is also associated with vasogenic edema in the adjacent cerebellum, and also some mass effect over the brainstem.
Mm-hmm.
So,
okay, sorry.
Yeah.
Well,
both permeability and there seems to be an increase in the relative in RCBV and also in the permeability.
That's right.
Yeah. So RCBV value is. So it is a leaky.
The leakage is not obvious here because actually it didn't reach the baseline anymore.
So it is a highly vascular tumor located in the fourth ventricle in a 29-year-old male. So, I mean, ependymoma.
Hypervascular tumor.
It's hypervascular.
I told you, then we can calculate the ratio.
Yeah.
At 12.4, but honestly, I don't know if any calculation here could be reliable, but it's half of the voxels are contained, at least half, are contained by vessel. Then again,
hemangio something.
Hemangio something, and that's right. It was hemangio something. It was an hemangioblastoma. Here's a arteriography. Another case. You dare?
We see a mass in the cerebellum central with central cystic components and quite homogeneous contrast enhancement at the border. And considering the age, I would again think of a hemangioblastoma.
Well, then you need additional things. Okay, hemangioblastoma, you would need at least perfusion image.
Yeah.
Okay, I won't give you any perfusion image. I will give you first diffusion. It's not highly cellular. Okay, then it's less reliable that it's was a tumor in this region which is highly cellular. It's the other one. Medulloblastoma. Okay? But usually it's highly cellular. Medulloblastomas are highly cellular. Okay? When they are not so highly cellular and they are not hypervascular.
Polycystic astrocytoma?
Well, why not? It's a good option. It could be actually entirely right. Actually, here it was an ependymoma. Okay? Then first perfusion, when you have this kind of tumor and the posterior fossa, and when you do the perfusion image, when it's extremely, when it's highly vascular, you go for hemangioblastoma. Okay, when it's not, you compare it with diffusion image. When it's highly cellular, rather go to medulloblastoma. When it's not, rather epenymoma or pilocytic astrocytoma. But usually, the appearance of the lesion itself can be different. Astrocytic pilocytic astrocytoma, they have a large cyst, while the epenymoma, it's a mass quite a bit heterogeneous with smaller cysts inside. Okay, another case. Then we need something else.
Yeah.
Okay, we agree. Now, I mean, this is the topic of.
Okay, now we have diffusion restriction indicating a higher cellular tumor, and as we've just discussed, and he's 9 years old, I would opt for medulloblastoma.
That's right. And when you look at perfusion, you may have a slight hyperperfusion in medulloblastoma as well. Okay.
Okay, thank you. Yes, we have a mass in the right cerebellar hemisphere with a rim enhancement and a fluid level in the cystic or necrotic cavity. And that diffusion in the bottom. Yes, and yes, I had. There's no edema, but.
Okay, no, here it is.
Okay, diffusion there. Okay.
Diffusion, ADC,
Yes.
no decrease. Maybe a little bit in the lower part of the level, the fluid level. Okay. That was the spectroscopy I showed you at the beginning, and not reliable at all. And you have to say that it's not reliable. Okay. And what about CBV? The only thing we see is quite a subtle vascularization, but especially a leakage.
Could be pilocytic astrocytoma.
That's right. Here with a large cyst, rather a pilocytic astrocytoma. Okay.
There's a micellation in the right parietal lobe. It shows homogeneous bright enhancement with a large edema, surrounding edema.
Okay, you missed something? Okay, then first, maybe you see here the core of the lesion has a lower signal on T2 than the surrounding edema. Then it suggests something again. Okay? Then you can imagine diffusion, where you have
diffusion restriction, so it's a higher cellular tumor.
That's right. Cellular tumor. What can we can keep going on.
And then abnormal spectroscopy, so a high colline peak. And I think it's lactate, or a high lactate peak. 1.2.
1.3 at lactate. This is a long TE. Okay? Then at long TE, lactate are negative. Okay? When you see a large peak at 1.3 positive at long TE, it's lipids. Okay? Highly cellular with choline, but not specific, and lipids with a homogeneous enhancement, lymphoma. Okay? And the perfusion also confirms this. Mainly, a small increase of perfusion, but also with a large leakage. That's why you have a large enhancement here. Okay? just if you want to keep going on. Almost the last case.
Enhancing nodular area with surrounding edema. Can't really see that like the hypo intense area where the enhancement was, not that much at least. And on diffusion weighted imaging, it is restricting.
CBV, well, I have only this map, but there is no increase.
No increase in
On
vascularity.
CBV, and again, spectroscopy. You see first choline peak, but not specific. And here you see two things. You have a negative peak at 1.3. Lactate. Okay. Because of the long TE. And at shorter TE, then your lactate are positive, but you have another peak at 0.9. This is lipids. Okay? And then, altogether, it looks like lymphoma. Okay? Well, it's very similar across different things, just to show that it's very similar across the techniques and so on. A choline peak, which is not very specific. This lactate, negative on long TE, positive on shorter TE, but also with lipids. Okay? And that's why also quantification it's quite hard, because this positive peak at 1.3 is a combination of lipids and lactate. And it's because of the peak at 0.9 that we say there's a part of lipids into. And perfusion image show you there's no increase in perfusion, very slight, but not so significant, mainly a leakage, and diffusion shows that there's a restriction, highly cellular. And altogether, it's again a lymphoma. Okay, then we're about to be, I will maybe skip that one. Let's say here, it was quite a weird case. You see on the initial examination, you see this lesion did not enhance. Okay, 4 days later, the lesion enhanced. And we screened this patient 6 weeks later again. There was no, we looked for a cancer, whatever. There was no cancer. Then 6 weeks later, we thought that it did not enhance anymore, and we thought that it was inflammatory. And 3 months later, you see, it doesn't enhance still. Maybe it changed a little bit in the middle, but what you see on the spectroscopy, there's a peak of choline, okay, far above creatine and NAA. There's some lactate here, combined with lipids. Then it was a glioma. Okay, glioma, and it has been as biopsy was mentioned here. Okay, this is another case, something we don't know really much, but we know better now. It's a woman, 39 years old, initial seizure. You see this infiltrative lesion here. You see there's a very high CBV, almost 4, a ratio by 4 although you don't have any real contrast enhancement, you have very small foci of contrast enhancement. On perfusion, you have a hotspot here related to the eye perfusion. And even if this image look quite benign, okay, infiltrative, but benign, the perfusion was not benign at all. And actually, there was a biopsy, and it was a glioblastoma. Then you have to keep in mind that certain lesions which do not really enhance yet, because the blood-brain barrier is not destroyed yet. You can have this highly vascular lesion without contrast enhancement. Okay? Okay. About the last one. Here, yeah.
On dark fluid flare hyperintense, T2 hyperintense. On post contrast, there is a ring enhancement, and there is a high choline ratio and lipids and lactate peaks. So maybe it's an abscess. Lactate.
Well, actually, the core, it would be a necrosis. The core of the necrosis has not a restricted diffusion. It's only the edge of the lesion, which has restricted diffusion. You know, quite similar. That.
So it's an open rings.
That's right. Here's
open
an
rings.
open ring. You have to go back also to morphology, and I have to look at the morphology of the morphology. This is an open ring.
I didn't look on the ADC.
Yeah,
it's a monofocal acute inflammatory demyelination.
That's right. Exactly. Sorry. Then on the spectroscopy, you had a. Can you go back? Well, then you have an open ring enhancement. Spectroscopy is quite tricky because you see a peak of choline. Okay, you have some lipids. You have also lactate. Then it's a tumoural profile, but this tumoral profile is not specific. You do perfusion image. You don't see any hypervascularization. You only see a leakage. Okay? Then it's not a metastasis. It's not a glioma. Okay? You would have some, with all this hypervascularization, this contrast enhancement, you would have some hypervascularization in metastasis in glioma. Usually at least a ratio above 2. Here the ratio was, I guess, below 1, mostly because of the leakage. And actually it was an ADM. Okay. Then just a case of pseudo-response in a patient having a glioblastoma. You see only 2 days after the introduction of the anti-angiogenic therapy, you see the enhancement of the glioblastoma, which decrease quite importantly. You don't see a highly vascular lesion. As I told you, that at the beginning you have a strong leakage, and after you see this leakage disappearing. And this disappearance of the leakage is associated with the reduction of contrast enhancement. That's why I told you this anti-angiogenic therapy in a certain way gives the appearance that they are healing the vessels. Okay, you don't leak that much. That's why you lose this overshoot over the baseline, and also that's why you have a decrease in contrast enhancement. And actually that was a pseudo response. That was, I guess, the last cases. Just to say that, well, if you're quite a bit trained, you can perform the complete examination, but almost impossible in one session. You can do diffusion, perfusion, spectroscopies, and you'll demonstrate choline, no lactate here, possibly a little bit of lipids, and you can even try to go further doing functional MRI before surgery to locate language, corticospinal tract, and so on. Okay, then remember, oops, well, remember then history of the patient is important, especially history of the treatment, how far you are from the treatment, what kind of treatment the patient had. For diffusion, mainly cellularity. Perfusion, have to keep clear in mind that in tumoral lesion, we are looking for highly vascular lesion. And in order to have these things very clear, you have to also appreciate the leakage. And for spectroscopy, then there's a kind of tumoral profile with high choline, high lipids, and low and high lactate, but it's not specific. You can have this kind of lesion even in infectious disease, for instance, and this combination altogether that allow you to better do the initial diagnosis and then follow up. Then thank you for your attention, and I wish you the best.